My name is Dr. Ajay Kumar. I am a consultant physician and diabetologist practicing at Patna. I am going to talk about the changing paradigm of treatment in type 2 diabetes. The paradigm has gradually evolved over the last couple of decades, and this is largely driven because of number of landmark trials. Initially, these trials were looking at the comparison between intensive glycemic control versus conventional control. And all these trials eventually convinced us that treating blood sugar to target is extremely important. It gives great dividends in terms of reducing the microvascular complications. But we also realized from these trials that if glycemic control is achieved much early in the natural history of type 2 diabetes, it also has a huge impact in reducing the macrovascular complications. But then another change in the paradigm was brought about by dedicated cardiovascular outcome trials. What we have seen over the last 1 decade is number of trials coming up with DPP-4 inhibitors, GLP-1 receptor agonist, SGLT2 inhibitors, and even with insulin degludec. I am going to focus this talk on the cardiovascular outcome trials with GLP-1 receptor agonist. GLP-1 receptor agonists have established themselves as an important anti-hyperglycemic agent because they provide glycemic control by providing a glucose-dependent stimulation of insulin secretion from the beta cells of pancreas and glucose-dependent suppression of glucagon from the alpha cells of the pancreas. And with this, the additional advantage of weight loss, beta cell protection, and now cardiovascular protection adds a lot of dimension to use of GLP-1 receptor agonist in our clinical practice. Now, if we look at the CVOTs with GLP-1 receptor agonist, we can actually classify them into 3 different zones. The first set of trials were actually done with the exendin-based GLP-1 receptor agonist. And in that context, we have 2 results. One is the ELIXIR trial for lixisenatide, and the other is the EXCEL trial with exenatide. Both these trials clearly demonstrated that lixisenatide and exenatide were non-inferior to placebo in terms of cardiovascular risk outcome. That clearly establishes the safety of this class of drug in patients of type 2 diabetes, which clearly means that if you do use these classes of drugs, you will not cause any harm. But unfortunately, these 2 drugs could not demonstrate any cardiovascular benefit. Then we have another set of trials that was largely propelled by the liraglutide, and the trial was LEADER. This was the first GLP-1 receptor agonist trial which not only demonstrated superiority in terms of reduction of 3-point MACE, and that was statistically significant. This benefit was largely driven by a reduction in cardiovascular death. In this trial, the individual components of atherosclerotic cardiovascular disease like myocardial infarction and stroke were not favorably affected. They were neutral. However, the robust impact in reducing the cardiovascular mortality led to a reduction in the 3-point MACE. And in fact, if we look at the expanded MACE with liraglutide, it also demonstrated that the risk for heart failure hospitalization and need for revascularization procedure was also decreased. And therefore, liraglutide was established as a drug which can reduce the cardiovascular risk. The regulatory agencies like FDA actually mandated in their changed guidelines that if a patient of type 2 diabetes has got concomitant atherosclerotic cardiovascular disease, it is imperative upon the physicians to use this class of drug. Then we also have the results with the weekly semaglutide, which also shows a statistically significant reduction in 3-point MACE. But contrary to liraglutide, this benefit with semaglutide was largely driven by a reduction in the incidence of stroke rather than cardiovascular death. But nevertheless, the 3-point MACE reached a statistical significance. And then very recently, we have another publications, one with albiglutide and the other with dulaglutide, which is a weekly GLP-1 receptor agonist. And both these GLP-1 receptor agonists have clearly shown not only non-inferiority, but superiority in terms of reduction of 3-point MACE. What transpires from all these cardiovascular outcome trials is that now patients of type 2 diabetes having concomitant atherosclerotic cardiovascular disease should grossly benefit by use of this class of drug. They will not only have adequate glycemic control, they will be avoiding the risk of hypoglycemia, they will have the additional advantage of weight loss, and on top of that they will have reduction in the cardiovascular risk. All this translates into good news for patients of type 2 diabetes. It's also an important area of development that when patients fail on multiple oral drugs, which injectable should be used? Normally we generally start with insulin, but with these properties of GLP-1 receptor agonist, I think now the ADA ESD guideline tells us that we should be using this class of drug as first injectable over a preference when we compare with insulin. However, it is imperative to understand that GLP-1 receptor agonists as a class are quite expensive class of drug, and therefore those patients who cannot afford a GLP-1 receptor agonist for their cardiovascular risk reduction, they will have to fall back upon the SGLT2 inhibitors, and for the first injectable use they will have to fall back upon the use of insulin. Thank you.